Good evening and welcome to the History of Medicine webinar series here at RCSI Bahrain. This is our sixth episode in this series, and I'm very happy to welcome you all here today. Could I have the next slide, please? So we have three more lectures planned, and all of them promise to be of significant interest. But today, next slide, please. We're privileged to have Professor Thomas Walsh from the Department of Surgery at RCSI present to us on the history of surgery. This session will be moderated by Professor Wayne Cunningham, who's Head of Family Medicine here at RCSI. Professor Walsh is a well-known surgeon in Ireland with a significant clinical experience in esophageal and hepatobiliary surgery, which also form his main research interest. He was at one time past president of the Royal Academy of Medicine in Ireland, and was also the editor of the Irish Journal of Medical Science for 5 years. His title today, History of Surgery and Surgeons, promises to be extremely interesting. If you have any questions, and I hope you have many, you can use the text box to register your question, and hopefully we'll get to it today. So without further ado, let me pass you over to Professor Tom Walsh.
Good evening, everybody, and thank you very much, Prof. Martin, for the invitation. It's a great privilege to be invited to speak on a topic such as the history of surgery, a topic that, having taken up the challenge, I must say, I became fascinated with. I'm not a medical or surgical historian, unlike Prof. John and others, but I found an extraordinary journey as I went about checking out the highways and byways and side tracks of surgical history. I suppose one thing I became aware of was I became fascinated by how surgery, ancient surgery, how it would fit with modern times, and I will try to do that, during this talk, see how certain surgeons and certain operations would have fitted with modern times. But I suppose getting into it, surgery, I suppose, is as old as mankind, because I suppose Homo sapiens has been around for about 250,000 years, and from the beginning it was prone to injury, at least soft tissue injuries, and had to do something about them. I suppose our view of history is skewed because Homo sapiens didn't start writing until about 4,000 years ago. So 245,000 years of his activities on Earth are obscure or lost to us. So we tend to make certain assumptions about history, and some of the assumptions are based on how primitive people have, how we have observed their behavior, I suppose, over the past 100 years, and have made the assumptions that what they did, our pre-writing and prehistoric generations also did. And we can make a certain assumption that they, when they had wounds, they covered them with certain materials, with leaves, with parts of plants. Cobwebs were an obvious wound dressing, and these were actually little boxes of cobwebs were given to soldiers in their packs for the Battle of Crecy to staunch the bleeding. And while that might seem, to have no basis, when I did my first attachment to vascular surgery, I was very surprised to find that when operating on an aneurysm and the wounds on the aorta that were created by the needle track wounds that were still spurting blood, the surgeons wouldn't pick up a large needle. They would pick up maybe a 6-0, and they would just suture the adventitia around those needle holes, which looked exactly like cobwebs to trap the platelets and form clots. The management of hemorrhage was also similarly managed with spiders' webs, with various powders. Apparently North American Indians have shown that they have powders which can staunch hemorrhage through hot stones and through burning, and through the Tibetan monks had a mixture of saltpeter and sulfur which they used. And even in the 18th century, soldiers used to discharge gunpowder over the amputation stumps. I suppose the prognosis was so bad that it didn't matter what you did, you weren't going to make things worse. And bone needles have been found, and they presume that the bone needles worked in the same way as the Maasai tribe, who make a series of holes in the skin with a sharp awl and insert long acacia needles or thorns through it, and then bind the whole thing together, like I suppose a modern day boot. And South American Indians had a trick where they brought the wound edges together and then got a termite to bite it, and then screwed off his head and left the head holding the wound edges together. And of course, broken bones would have been common, and would have been a major problem for the hunter-gatherer tribes. And they probably used splints, and some American Indians have used strips of bark, and others have used soft clay that hardened like plaster of Paris. And somebody has looked at the fractures and found that at least more than half had healed satisfactorily. And I presume they used logic also for orthopedic reductions. The Aztecs had an extraordinary, I feel like, technique for broken bones, which wasn't rediscovered until the 20th century. And if a bone failed to heal, they would take a splinter of wood, and if a long bone failed to heal, and they would put it down the shaft of the bone and bring the two parts of the bone together. I don't think we've had an audit on their success rates, but it was certainly an idea well worth pursuing. Of course, trepanation has been conducted for thousands of years. It was felt that the first or the oldest of these was in the Alsace region, which dated about 7,000 years. But not so long ago, along the Dnieper River near Belarus, there were skulls found that were probably 12,000 years old. And the thing about it is that the majority of them healed. So surgeons, or the trepanners, who must have had a special role in society, were obviously learned from their mistakes, and some had repeated trepanning. One particular chap in an Inca from Cusco had 7 holes in his skull, and they feel that at least several of them were made on different occasions. And while some were done for head injuries, the majority were not. The majority were for intact heads. And it's hard to know, they must have had some success, or it wouldn't have persisted, I would imagine. And they have, it certainly persisted up until the beginning of the 20th century. Now, my first insight into this particular business came when I was a student in Zambia, and I was a 4th-year medical student just going into final, and I was given charge of the male surgical and the pediatric ward. Now, that wasn't because of my expertise. The consultant and the only other doctor in the place had been an intern in Holland on the previous year. But on one occasion we had a chap who had a history of trauma, but the history wasn't to clear. He had a very severe headache, and Dr. Otto asked me to do a lumbar puncture. And when I did and took out the trocar, there was a jet of CSF across the room, and I quickly put the trocar back again. And of course, I went looking for Dr. Otto because I as a Fort Med student, I'd heard of the dangers of coning, and so I brought him to see the patient and took the trocar out again, and now there was just drip, drip, drip as it would normally be. And of course I asked the patient how he was, and he said, "I'm great." He said, "The headache's gone." And when I came back to Ireland, again and again I asked people, why are we not performing craniotomies on patients with head injuries? And it's interesting that it had gone out of fashion for almost the entire 20th century, but in 1999, after a publication by Guerra and his colleagues, and they reported their experience of decompressive craniotomy, it's back again. And I was speaking to one of the neurosurgeons in Beaumont recently, and he described that it's regularly performed now for traumatic brain injury, for acute subdural hematoma where the flap is left off, and for malignant middle cerebral artery stroke, which has an 80% mortality. The only caveat is that often, while it saves the life saved might be of such a poor quality that patient and family may wish that they had not survived. So we come to Mesopotamian medicine and the Sumerian civilization, which seemed to have been driven from these parts up into southern Iraq with the rising water levels when the Ice Age caused the great melting, and the sea levels rose, which was, I suppose, gave the legend of the flood. And these people were the first to write. They had their cuneiform writing, and these tablets they wrote on were about the same size, apparently, as the current mobile phone. And they wrote their prescriptions, and this is the prescription here. Apparently, it's a prescription for beer, amongst other things. So they were an enlightened race, and they apparently, of the 30,000 cuneiform tablets, found 800 deal with medicine, including the world's first prescriptions. They were succeeded by the Babylonians, and again they wrote on tablets of clay, and they left some remarkable case histories. And in one, they describe a patient who coughs continuously. What he coughs up is thick and frequently bloody. His breathing sounds like flute. His hand is cold, his feet are warm, he sweats easily, and his heart activity is disturbed, which is a wonderful description of bronchi in TB. And somebody pointed out it sounds like the lines of the song by Roland to Mimi, "Your tiny hands are frozen" in La Boheme. But surgeons were still not considered decent doctors, and that's a prejudice apparently that persisted right into the 19th century, apart from some patches of enlightenment around the world at different times. But they had a full range of instruments, and they practiced bladder stone retrieval and herniorrhaphy. Around that time, their greatest king was Hammurabi, and he introduced a lot of laws governing different aspects of life. His laws on medicine, he, for instance, set out the fee schedule that doctors could charge. And he said if a doctor has treated a man for a serious injury and cures him, or opens a swelling with a knife and saves his eye, he's to get 10 shekels. And if a patient is a free man, the payment is 5 shekels, and if it's a slave, the owner must pay 2 shekels. Now, at that time, the going rate for a month's labour was 1 shekel, so that was a fair reward. On the other hand, there was a fairly stiff medical legal code, so that if the doctor inflicts a serious wound with his knife on a free man's slave and kills him, the slave must be replaced. And the going rate for slaves at that time was apparently 10 shekels or 12 shekels for a female slave and 20 shekels for a good working male slave. But if the doctor has treated a free man and caused a serious injury from which the man dies, or if the man goes blind, then the doctor's hand is cut off. So I would imagine that most surgeons would stick to minor surgery. Around the same period, Egyptian medicine was, and I suppose the Egypt was united under the first pharaoh who ruled the whole basin. And they introduced the first calendar, they introduced hieroglyphics, they built the capital of Memphis. And the first treatise on surgery was written 4,700 years ago by Imhotep. He was a doctor, an astronomer, an architect, and a high priest, and subsequently a god. His writings didn't survive, but they were often referred to, and they were respected. But the papyri that survived, that dealt with surgery, and Smith, the papyri that Smith acquired, seemed to deal with surgery, and they were very systematic because they dealt with diseases from head to chest, thorax, abdomen, and it was obviously a systematic approach to these illnesses, and they made sense for their time. They contained the first known descriptions of the cranial sutures, the meninges, the external surface of the brain, etc. And they knew how the heart and the vessels and linked up with the kidneys, the spleen, etc. But some of the most remarkable surviving documents come from Indian surgery, because their written documents about surgery at the time in the Susruta Samhita describe 121 surgical instruments, and they described how broken bones should be splintered, how wounds should be sutured, how fistulas cauterized, how pus should be drained. They're dramatic and remarkable nasal surgery, partly because nose amputation was a common punishment for theft, and from a couple of thousand years ago, they were doing these remarkable flaps to replace the nose. They also had, because there were amulets inserted into the ear as ornament, and some of those got infected, and they had to repair the problem. So their plastic surgeons were superb. And again, they had some very skillful eye surgeons for removal of cataracts. And in their training of surgeons and of doctors and their training of nurses, they emphasized the need for training. They emphasized the need for complete cleanliness. When you contrast that with 4,000 years later or 3,000 years later in Vienna, it's remarkable. They were big into simulation and simulation training, and they perfected their techniques for suturing and bandaging on pickles, gourds, watermelons, and animal bladders. So, when you think about it, we thought that we were, first on the scene with simulation. Around this time, and later, the cult of Asclepius was, at its height, with around 300 temples dedicated to healing, and there were a core group of physicians, and apparently to get into one of these places you had to come with a gift and set it at the god's statue, and then you were given a sleep-inducing potion, and when you woke up you were visited by the consultant, who made all the right noises, etc., and said all the right things, and some interventional procedures took place there. Boils were lanced, etc. And around this time, they started to forget about the idea that disease was caused by demons and by spirits and by gods. Anaximenes understood the importance of air as a source of life. And Alcmaeon from Croton, he was firmly of the belief that the disease was not due to demons, etc., but due to an upset of various balances. And he was a pioneer of this dissection. And Empedocles also maintained that life was an imbalance between earth, air, fire, and water, apparently laying down the foundations of biology and chemistry. At least they were on the right track. There was a school set up at Cnidus, which is marked in red there. This is off the coast of Turkey, and it was part of Greece at the time. And it was apparently set up not by some of these famous guys, but by their assistants, who had performed, they got an awful lot of exposure with their priestly overlords, who probably didn't do any of the physical stuff. And they were very practical, and they set up a school of medicine 700 BC in Cnidus. And right beside that was the island of Kos, just north of it, where Hippocrates was born. He was born into a medical family, and this was an extraordinary time in Greece because it was their golden age. And Pericles was then making it big in politics, Socrates and Protagoras in philosophy, Herodotus and Thucydides in history, etc. And it's extraordinary. It is very fascinating about history that you think that world peace and the internet are just around the corner when you have sort of the flowering of an age of genius like this. But it doesn't seem to happen. History seems to lurch forward and lurch backwards and lurch sideways for a long time. Hippocrates' writings, I think of all of the ancients and not so ancient writers, his thought process seems to me closest to our age. He, on surgery, he said, the surgery is concerned with the patient, the operator, his assistant, the instruments, the light, the time, the method and the place of surgery. You could hear that being said in a lecture theatre today to the young trainees. I would not cut for stone, even if the patient in whom the disease is manifest. I suppose the problem there was that the outcome for cutting for stone was so appallingly bad that it just unnerved him, he obviously felt that they would have to wait until something less horrendous was available for the patients. And of course, on the Hippocratic Oath, he set the foundation stone for modern medical ethics. His writings obviously repudiated the old divine intervention bit, and his book on surgery was regarded as the best bits. The students in his, under his tuition, like the students in RCSI today, they first were asked to take a history, then perform a detailed examination, inspection, palpation, and auscultation. Percussion actually didn't come until later, about the 17th or 18th century. And he described the typical findings in the lungs of inflammation. Then the students were told to smell and taste the various body fluids. I don't know how that would go down today. They had to give a prognosis. They had to advise treatment centered on rest, diet, and climate. And I suppose that was what they had. And, you know, it sounded all very, very feasible. And I've recently, you know, been given to wonder about if he was here today, how he would feel and how he would think. And I think of all of the ancients, he's the one who would have probably fitted in most easily. Back then he said, life is short, the art takes long to learn, opportunity is fleeting, experiment dangerous. And a young trainee today would probably say you should try training during a COVID pandemic, where the rotas have extended to 1 in 8, where European Working Time Directive restrictions mean that you've got to go home in the morning after admitting a very interesting patient. How can you learn surgery? And of course, the current medical legal environment makes it very difficult. He said some other things, and they all resonate today. If the operation is necessary, one should act at the very beginning. Once the illness has reached a peak, it's better left alone. We would say, operate immediately if it's straightforward, because we understand the cytokine storm that follows an illness and an inflammatory problem. And we would say exactly the same as he said. We would say we have a 6-day to 6-week rule that you must never operate between 6 days and 6 weeks. Or when I say we, I mean, like in Britain and Ireland, we learned that from when we were, you know, first-year medical students. And I think in Bahrain, the same rule applies, the same law is followed. More of that in a short while. He said if two elements occur in the same time, the weaker is obscured by the stronger. And I mean, you know, we say the same thing. Comorbidities can be obscured by dramatic presenting symptoms. And people will often find themselves in the middle of an operation to find that, oh, so this person is at some degree of cardiac failure. Yeah, well, we didn't know that. Or this person has renal impairment. You know, we thought, you know, it was just dehydration. He said, even if they regard their illness as serious, many patients regain health simply through satisfaction with an understanding doctor. And we would say exactly the same. In most cases, things will settle in conservative management, and we can operate electively. How many times are we called by a radiologist to say, hey, you know, we've got a chap here with a perforated colon, you better get in and operate. And you go and find a very sick guy, but his abdomen is soft around apart from the LIF, and you know that he is perforated, yes, but it's walled off, and you don't have to operate. Yes, in the past, surgeons would have, and they would have gone in and done a Hartmann's, and the patient probably wouldn't have survived. Again, do not disturb a patient during or after a crisis. We would say sit out the cytokine storm, and if necessary, involve our IR people. And he had a view on the effect of obesity. And I just want to raise this point here and bring us right up to today, or at least a few years ago, when a paper was published, which has actually altered the practice of surgery in the continent of Europe. And this was a study proving that early cholecystectomy was better than elective cholecystectomy. And people who know me know I get very worked up about this topic. And they published this study, but when they said that early was better than elective cholecystectomy, which goes against everything I know, they defined elective cholecystectomy as between day 7 and day 45. In other words, right smack bang in the middle of the 6-day to 6-week rule, which we on Hippocratic would have said don't operate. So we wrote a letter to the Annals, to the editor of the Annals of Surgery, and we gently pointed out that, you know, that the 6-day to 6-week rule, you know, hasn't been followed here. And they very curtly reported back to us that we have defined early cholecystectomy as within 24 hours and delayed cholecystectomy as 7 to 45 days. Other definitions for early or delayed may exist. Semantic subtleties do not change the major conclusion. Now, obviously to this group of surgeons who conducted the largest trial ever on this study and enrolled 36 hospitals, to them operating between day 6 and day 42 was a matter of semantics. Well, we watched this space, and in the UK, where the majority of patients are operated on electively, the mortality is 1 in 500. Only 16% were operated emergently. In Germany, where 77% were operated on emergently, the mortality was 1 in 60. That's 10 times higher mortality rate. And, you know, there we go back to Hippocrates, and he would have understood and he would have cautioned, if he was here today, do not operate when the patient is in crisis. Wait for the crisis to pass. Wait for the inflammation to settle. Okay, getting back to his times, he said that first, do no harm. And he also said, to be a good doctor, you must first be a good human. And I think we would all agree with that. He was followed some time later by Plato and Aristotle and other great Greeks. And then the center of attention moved to Rome. And the Romans didn't have much in the way of surgery or much in the way of, they had very little time for surgeons or for doctors in general. These were considered lower life. They apparently had very good dentistry, or maybe not the Romans, but the Etruscans before them, who had practiced with gold wire and gold prostheses. And apparently the only word from Roman period is the word oncos for a bulky thing, and oncology comes to us from there. And by 30 AD, Celsus was a doctor in Rome, and he published an extraordinary text, and he had some amazing clinical signs and descriptions of operations. He did a magnificent description of a lithotomy, which is worth reading. And he gave rubor, dolor, calor, and tumor, and we've all learned. One of the books had said that function lesa was also added, but this actually wasn't added until, as according to Bailey and Love, it was added by Paddy Fitzgerald. And when I was a third med student in Vincent's, I worked with Paddy Fitzgerald. He was the first surgeon I worked with, and an excellent surgeon as well. But he added apparently the fifth sign, or at least according to his contemporaries, after Celsus. And his book covers a vast breadth of surgery. Nursing care, Ramesses covered this area, and he allowed the women who had somebody at home who was sick, he allowed them to get off the temple construction and get back and look after the family. It was very, very reasonable and very wise. But as a profession, it was in India where nursing first arose, and where the first hospitals were built as well. And the Hindu texts frequently mention the role of nurses. She should be clean, intelligent, knowledgeable, with sympathy for the patient, and must be absolutely loyal to the doctors. And maybe we should try and reintroduce some of these caveats in our nursing schools. Anyway, Christianity was a mixed blessing by the care of the sick, but quite a number of independent Roman women who were Christian at the time went into building and caring for turning their houses, their villas over to hospitals. Another great name around this time was Galen, of course. And he was very influential, and that was probably a good thing and a bad thing. And he came from Pergamon, which was again part of the Greek Empire, but in Western Turkey. And he attended the gladiators there and then took off to Rome, where he again became involved with gladiators. I suppose that was a very good way to learn anatomy with gladiatorial injuries. And unfortunately, because autopsies were prevented, his understanding of anatomy came from animal dissection, and that became a problem with because so many people had to learn what was wrong for so many centuries after Galen. But he understood the role of the recurrent laryngeal nerve in loss of voice. He understood that urine came from the kidneys via the ureters to the bladder, and etc. He had a lot of other. He became very wealthy. He had his favorite operation, I think, from which he derived some of his wealth, was uvulectomy, and that was considered by some. I don't know if Graham was as cynic as the tonsillectomy of the modern day ENT surgeon. His influence was good and bad, partly, I think, because the church also, I suppose, didn't encourage or allow. They discouraged their priests and their from exploring medicine and surgery, especially after about 1150. I suppose that their fatalistic approach to life. I mean, this is all in the hands of God, so why should you try and intervene? Getting back to hospitals, the first hospitals were founded in Sri Lanka around 500 BC, and there were many effective hospitals in India around that time. We mentioned the Roman contribution. Leprosarias were built out of town, as you can imagine, and there was one of the finest of all hospitals was the Al Mansur in Cairo, which was a gigantic building separating all the different specialties, with a library, lecture hall, and outpatient clinics. Around that time, Ibn Ishaq, who studied in Greece and returned to Baghdad, and he produced a brilliant translation of Hippocrates' work. Abu Bakr al-Razis was an Islamic scholar who wrote a masterly description of measles and smallpox, and he treated hernias. And his Kitab al-Hawi fi al-Tib, comprehensive book of medicine, was translated into Latin. And apparently until the 17th century, it was an authoritative work. And Ali ibn Sina published the canon, which was systematized all medical knowledge. Mind you, he had little regard for surgery, and I suppose that's probably why he suffered burnout. Al-Khazim was a very famous, and he goes by the name of Al-Zahrawi as well, Zahrawi, and he produced an extraordinary book, this Kitab al-Tasrif. It was an extraordinary book because he obviously had an extraordinary breadth of knowledge, and in it he pioneered the use of catgut for internal suturing. And he said he got that for because I think his dog ate his oud strings and they didn't reappear. So he obviously understood that they were dissolved. He was the first to describe a lithotrite, and when Sivale in France produced the design of that, he never attributed it to Al-Zahrawi, even though that work was very well known then. Likewise, Paré introduced temporal artery ligation for migraine, and this also had been described in his work. So many took credit for his inventions afterwards, but and he was the first to recognize the hereditary nature of haemophilia. I won't go through this except to say that Hugo of Lucca and his son Theodoric, they were the first to go against the idea of laudable pus, and they described, and this going against that idea was regarded as one of the most heretical statements in modern medicine. They also used wine to cleanse wounds, but nobody was listening. An operation that's unique at this time, and for the past 2,500, maybe 4,000 years, was the operation for cutting for stone. And ancient civilizations were prone to bladder stones, probably due to poor hygiene or hygiene of the time. And Celsus's description is very graphic, and it's well worth reading. But surgeons all down through the ages had techniques for removing stones, and then they probably kept them to themselves in case of financial loss. But the mortality was at least 30 to 50%, and it could be much higher. There was a famous French lithotomist, his name escapes me, and he felt that the only way to keep the mortality down was to avoid operating on elderly people because of the risk. And of course, elderly he defined as anything over the age of 15. Back around this time in France, Frère Jacques he decided to do medicine. And he qualified as a stone cutter at the age of 46, but he failed his exam because his pre-op workup didn't suit the people of the time, because he hadn't included bloodletting and laxatives in his workup. But he operated on the king's shoemaker, and the shoemaker was back to work in 3 weeks after he's been cut for stone, and so the king granted him his license. And he worked in Versailles initially around there, but all of these stone cutters had to have one thing. They all needed a fast horse, because once the body count started building up, they had to move on to the next town. And luckily, there was no internet, so they could start off again. And I suppose the pain of the bladder stone was appalling. It's interesting that I work for a surgeon in the south of Ireland, and he was a man of few words, but he would say when we had somebody with a bladder cancer that, take me anyway, but not through the bladder, was apparently a phrase that people used at the time. And unfortunately, as luck would have it, he died of bladder cancer. So when he returned in 1701, when Frère Jacques returned to France, obviously to Versailles, they hoping that they'd have forgotten him. There was a Marshal de Lorges who wanted to be sure that he was able to do his job. So he watched him operate on 22 patients without mortality, and he said, okay, let's go ahead. Unfortunately, he died post-op, and Frère Jacques had to get back on the horse again. He apparently removed 4,500 stones and 2,000 hernias between Amsterdam and Rome. William Cheselden in England became one of the greatest anatomists and one of the greatest surgeons of his day. And there was a clash with the Barber Surgeon Society because they were looking for the bodies, and they were claiming that he didn't have a right to get the bodies, the dead bodies. And anyway, they continued to fight, and he continued his dissections on his dining room table at home. I'm not so sure what Mrs. Cheselden thought about it, but he could do apparently a lithotomy in about 3 minutes. This chap here on the left is a Dutch chap, Tulp I think was his name, and he's holding a stone and he's holding a knife, and he wasn't a surgeon. He was a patient, he was a blacksmith, and he was so fed up with his own pain that he sent his wife off to the market, and with his servant he tackled his own perineum and made the incision and dug out that particular stone. And apparently the story is true. I just was interested, Cheselden then fell out of favour with the king for some reason, and when the Queen died of a strangulated umbilical hernia in 1733, he hadn't been consulted. I was wrong. He could perform a lithotomy in 45 seconds, and his mortality was obviously about 10%, which was unknown at the time. But I think he also had a slightly different technique, and he operated to the side. This chap, Marius, had this stone operated on, and he set the operation to music. And I was going to play a little piece of it for you, but I think that I would almost prefer to have to undergo the operation for a stone. It's quite tortuous music. Then in the 16th century, these two guys, they pioneered the suprapubic approach. And the key to the suprapubic approach was to fill the bladder. So the bladder and the peritoneum and the bowel rose above the pubis. But all this time that Al-Zahrawi had described this lithotrite for insertion into the bladder for crushing of the stone, and this was modified then by Sidi Ali, who this nice set of instruments below belonged to, and he had a very good instrument maker. And of course, you know, the perineal lithotomy continued into the 20th century in some places, and suprapubic lithotomy was certainly continued until modern times, until shockwave lithotripsy. But of course, the problem with surgery was pain, and while there was analgesics in certain quarters, they weren't universal. And many of the physicians and surgeons, they trialed the drugs on themselves, like Halsted experimented with cocaine, and he obviously became addicted to it. And then to wean him off that, they used morphine, and I think he became even more addicted to that. But he kept going. MacDonald, who was the first person to give an anaesthetic in Ireland, sampled it 6 times to make sure it was working properly. Astley Cooper had said that the good surgeon needed the eye of an eagle, the hand of a lady, and the heart of a lion, because that was needed to ignore the screaming of the patients. This girl, Frances Burnley, who was a novelist, and while her novels were I suppose of their time, Jane Austen apparently picked up where she left off in one of her novels, and wrote one of her, I think, Pride and Prejudice from that. But she was wealthy and well got, and she was married to a French major or whatever, and she had a breast lump and it was diagnosed as breast cancer. And Dr. Larrey, who was Napoleon's surgeon, and Dr. Dubois, who was considered the best in France, they undertook to operate on her breast. And she described the pain of this. She kept a diary from the age of 10 until the age of about 87 when she died. And people subsequently have found her diaries to be, more valuable, I suppose, than her novels. But the only pre-op workup she had was she climbed onto the bed herself and she had a handkerchief placed over her face, but she could see through it. And she could see 7 surgeons approach the bed and her nurse, and she refused to be held down. And she said, when I saw the glitter of polished steel, I closed my eyes. When the dreadful steel was plunged into the breast, I began a scream that lasted unintermittingly during the whole time of the incision. So excruciating was the agony. And then when the wound was made and the instrument was withdrawn, it still was, she described as incredibly painful. She concluded that the operation was over, but no, presently the terrible cutting was renewed because they were scraping the tumor, the swelling off the breastbone. And I think we get the idea here that it was extraordinarily painful. And she was, as I say, wealthy and well got, and had there been any sort of pain relief in general, she would surely have been, surely been given it. I think it was fascinating the way that anesthesia was stumbled upon. Horace Wells saw a friend of his dancing when he took the laughing gas. These traveling shows used to have laughing gas, and this guy was dancing around, and Wells said to him afterwards, "You cut your leg there against the stool," and he said no. And he said, "Lift your trouser leg," and sure enough, there was a big gash, and that gave him the idea that this could be used for surgery. And he experimented with himself, and he thought he had his numbers worked out, and he gave a demonstration. Unfortunately, his demonstration at Harvard was on a fat person, and he didn't realize that nitrous oxide dissolves in fat, and he gave a totally insufficient dose, and the patient screamed, and everyone laughed. And of course, the idea that there was such a thing as painless surgery was considered nonsense again, and it was very upsetting for Wells. But William Morton was his student, or he was a student. He had abandoned his studies for the time being to, I think, work and earn more money, and he worked with him, and he worked on dosages, and then he worked on ether, and he gave another demonstration. He gave a demonstration in 21st of December 1846, and sorry, he didn't. He gave his demonstration in, I think, in October of 46. And when the message, yes, in October of 46, and when the message got to London, Robert Liston, on the 21st of December, went into the theatre one day, and he said he announced this Yankee dodge, that he would apply this nitrous oxide to this chap, this Frederick chap, a butler, who was for above knee amputation because of pain, chronic pain, and he had the leg off in 28 seconds, and he felt nothing. But when he woke up, he says, "Take me away, I can't have the leg off, I must die as I am." You can imagine hearing that now and thinking, you know, where is that consent form? In Dublin, shortly after that, just over Christmas, John MacDonald at Richmond was shown this article in in a British magazine, and on the 26th of December he said, "I must try this." On the 31st of December, a girl, Mary Kane, who had been out gathering firewood, and she fell, and a thorn went into her elbow. She got septic arthritis, and after 2 weeks she'd lost weight, had a bed sore, and she was in a terrible state. He decided to amputate. So he gave himself, he checked the ether on 6 occasions to make sure it was working. Anyway, he amputated. She felt nothing, and that was the first in Ireland. And then he knew Arthur Jacobs, and he made certain, he wrote the article that weekend, and he got Jacobs to publish it in the January edition of the journal, the Irish Journal of Medical Science, was the Dublin Journal. But at that time, sepsis was during the Franco-Prussian War in 1870s, the mortality rate for amputation was 76%. And in the early First World War, open femoral fractures, the mortality rate was 80%. So obviously something had to be done, but sepsis wasn't understood. And if I might just fly through this, maternal care in Vienna around that time was appalling. The maternity, women were offered, because of the infanticide, women, especially with illegitimate children, were inclined to kill them. So they offered care of the children of underprivileged women, provided in return they could, you know, have their students deliver the babies. And there were 2 maternity clinics. The first clinic trained medical students, and the second clinic trained midwives. And even the dogs in the street knew that you mustn't go to the clinic on Mondays, Wednesdays, and Fridays when the medical students and the doctors were delivering, but Tuesdays, Thursdays, and Saturdays. And some would give birth on the street outside rather than go inside, because the mortality was better. And these are the mortalities in the 2 clinics, the midwives clinic and the medical students clinic. And Semmelweis couldn't understand why the mortality was so low for the women who gave birth on the streets. compared with the clinics. And he checked every possible factor. He couldn't figure it out. And then his professor, Kolichka, died. He had been cut, again, medical students. He had been cut by medical students during an autopsy. And when he read the autopsy report, it was exactly the same as what was happening to the mothers. And he understood that if Kolichka had died of the same disease as the mother, it must have been the same cause. And the puerperal sepsis was not a female or a maternal thing. So he insisted on hand washing with chlorinated lime. And here was the result. There was a dramatic drop in mortality rates. And here is a comparison of Vienna. In 1823, they introduced the pathological anatomy. And that's when they started doing the autopsies, and the mortality went way up, way beyond Dublin. And then after the introduction of the hand washing, it dropped way down again. But you can see Dublin versus Vienna. Anyway, nobody was convinced. It was to be resolved by a discussion or a debate in front of King Ferdinand. Apparently, obviously, the locals didn't like this idea. He was apparently he was accused of being a traitor. He was from Hungary and a second-class citizen, apparently in Austria of the day, and he was deported back to Hungary. He reproduced the results, the same statistics in Budapest. He presented it to the German Surgical Society. Again, he was ignored. Now, he was a difficult personality, and he called some Würzburg professor a murderer and the Nero of medicine. He became depressed. He was tricked into entering an asylum. He was treated by the attendants. He was beaten up, and he died, ironically, of a septic hand wound at the age of 47. Okay, I'm going to flick through Pasteur and Koch. Only thing I'll say about Koch is that when we were medical students, the word TB wasn't allowed to be used on the ward, and Koch's disease was used instead. And of course, Lister read Pasteur's paper and used carbolic acid to get rid of these bugs, and sure enough, he started with creosote, in fact, which we used to paint our baling posts, then carbolic acid, and he published his results. And there was a great paragraph in a book, The Century of the Surgeon, where his visit to RCSI in Dublin, and he got a terrible hard time from the students, but he was well able to take it. Now, I just want to, the last 5 minutes here, I think I'm over time, but the last 5 minutes, I just want to show you this. In 1911, this man here, a farmer in West Limerick, was 66 years of age. He was my grandfather. He was born in 1845. And this was my dad, and he was born in 1898. But I was just thinking that if my grandfather had needed an operation in 1845, it would have to be done without an anesthetic. And if he needed his appendix out, if he had appendicitis, well, tough luck. The appendix wasn't removed until 1884-85. If he needed his bladder stone removed, it would have been done through the transperineal route, because it was only young people who were operated on. And if he needed his gallbladder out, again, he would have to wait until the 1880s. It's extraordinary that since the dawn of time, the arrival of man, writing, civilization, that surgery and surgery of the abdomen wasn't possible until my grandfather's time. And if you look here in 1870, Sir John Ericsson, who was president of the College of Surgeons in England, he taught in his valedictory lecture in 1878, he said that surgery was an exact science, but he predicted that 3 cavities would remain forever secret to the surgeon's knife: the cranial cavity, the thoracic cavity, and the abdominal cavity. And within 2 or 3 years, appendicitis was operated on. Groves in Canada was one of the first. Gallstones were operated on in 1882 for the first time by Langenbuck. And, even after Langenbuck, the diagnosis of gallstones couldn't be made until 1924, when oral cholecystography was introduced. Cholemic bleeding was a problem until 1935, when vitamin K was identified. Interestingly, now we have another problem, and I don't know how this is going to be resolved, because all of our surgeons are trained in laparoscopic cholecystectomy, but if they need an open cholecystectomy, there are very few who actually are trained and who can do it. They are very confident that they can do it, but when I think of how long it took to become comfortable in setting up for cholecystectomy, it will be interesting, because I think that those mortality rates reported from Germany are probably a reflection of that the problem with high conversion rates. And I leave it at that, because gastroduodenal ulcer surgery, again, it all started in the 1880s when the abdomen was first opened. Billroth 1, Billroth he joined the duodenum for the Billroth 1 operation, and he joined to the jejunum for the Billroth 2. Dragstead introduced vagotomy for ulcers in the 1940s. My boss in the matter was Sean Heffernan, who used to do Amdrup's operation, the highly selective vagotomy. And in 1989, when I was finishing my training, 1988, he came in one day. I'd collected 732 highly selective vagotomies that I was following up for him. And he dropped the Lancet in front of me in the theatre in the Mater. And there was an article by Colma Moran on the cure of H. pylori and the elimination of peptic ulceration. And he said to me, that's the end of us now. That's the end of upper GI surgery. And it would have been, I suppose, but there's always malignant disease. I leave it at that. Thank you very much.
Well, thank you very much, Tom. A truly interesting and exciting presentation and talk. Very impressive. I know how much hard work and long hours you put into getting this talk ready, and one would almost be misled by your comment that you're not a medical historian. Perhaps you should be called a surgical historian. I really enjoyed it. So if I could just pass you over to Professor Wayne Cunningham, who's kindly agreed to be our moderator this evening. Professor Cunningham.
Thank you very much. Thank you very much, Martin, and thank you, Thomas, for Tom, for that fantastic talk. There's some really interesting stuff there. There's no questions in the chat bar that I can see. Some good wishes from Alf, but no questions. So I might pose a question or two to you, if I may, and then people can write in if they like. One of the things that occurred to me was, do you? Oh, hang on, maybe I'm missing some. Can you think of any? Ancient techniques that have persisted largely unchanged into the modern workplace, or any ancient techniques that you've come across that you think should be reintroduced?
I suppose the techniques for reduction of dislocations, I suppose, have remained very similar. Minor modifications. The Hippocratic technique, which I've used myself, putting the foot into the axilla and pulling. There are. I suppose I would go along the rather than techniques, thinking of the Hippocratic approach in history taking, examination, in observation, in monitoring. There's so much in that, in the patient, sort of treating the patient as a whole rather than just you know, the sort of the compartmentalization of their problems.
Return to a whole person care model. No, I thank you. And Jamal, I think, has put up a very similar question to that. One of the things I've got 3 questions that I wrote down. If I may, I would like to ask you this one. You alluded to a number of, I suppose, paradigms, belief systems held by the surgeons of the day that turned out to shift. So, I mean, for example, you know, belief systems amongst the ancients of decompression craniotomies that then went out of favour. You had a shift in understanding of physiology from Galen, say, through to Harvey, and even, you know, Semmelweis's stuff with puerperal sepsis came up against the prevailing paradigm of the day that there was some other cause for all of these women dying. So I mean, medicine is littered with these situations where the belief systems that we have held have been proven completely wrong, or at least worth shifting. Allow me to put you on the spot a little bit, Tom. Thinking about modern surgery, do you think that do you have any predictions of paradigm shifts that you think we might see in the next wee while? Belief systems that are currently held in surgery that may well prove to be nonsense and will shift.
I think
there are millions of them in medical practice. Use of aspirin, use of statins, use of antihypertensives. These are all going to be shifting in the next 10 years, I'm predicting. Aspirin already has. What about surgery?
Well, yes, I think just like that, you know, the sort of blindly operating on every appendicitis, every, you know, perforated duodenal ulcer, etc. I think that we will probably get better at deciding on who to operate on. And currently, to me, the best way of deciding that is clinical abdominal examination. You know, I tell the students again and again how often I've come in, you know, when people said somebody has this, somebody has that, and you examine the abdomen and it's locally tender but soft elsewhere, and you say, okay, this, you know, is under control. That's one thing. I think understanding the physiology of the patient that we're dealing with, and understanding which of the cytokine systems that we're best to follow, because, you know, sometimes, yes, you have to intervene, and, you know, if you knew what their cytokine profile was, you might know if you could ride the tide, or if, you know, now was the wrong time. And, you know, I think that, again, you know, how do we manipulate that cytokine tide? You know, I think that that's going to be, I mean, I think surgery, you know, we'll be doing less and less surgery for just about everything. Cancer, for instance. Yeah. And it is interesting that if you're trying to publish a paper saying, you know what, we can probably reduce the need for operating, you shouldn't send it to a surgical journal. You know, they are absolutely, you know, they will fight you tooth and claw, you know. And yeah. I remember when I went, you know, to present the, you know, the neoadjuvant chemoradiotherapy work for esophageal cancer, you know, like I got physically sort of, you know, I won't say assaulted. I just got like index finger into chest muscles on a few occasions saying, you guys can't operate. We could operate and we can remove that. And you say, well, you mightn't need to operate. If you give chemoradiotherapy, it will melt away. And, you know, not a popular opinion, you know.
No.
So, I mean, but look what's gone. I mean, peptic ulcer surgery is gone. You know, thoracic surgery has disappeared. Well, the pulmonary thoracic surgery, a huge amount of it. You know, so prostatic surgery, you know, disappearing. So much of surgery will go, and cancer surgery hopefully will follow.
Thank you. Kevin, I think it's Kevin Dunn has put up a question. What does Tom think will people in the future think of our current surgical approaches? So what we're doing now, how do you think they will be viewed in the future?
I suppose it's fascinating, when we look back at people, in Semmelweis's time, in various other times, and people who tried to get a message across and nobody would listen, and people wouldn't listen. But then again, talking to Jamal, we have sent a paper, and you can see why we're kind of fairly strong on it, saying that early cholecystectomy mightn't be such a good thing if the randomized trials and the meta-analysis saying it's good, right? Because they're all flawed. I mean, when you look at them, they really are not every single patient randomized. But if you were pointing out to a journal that, hey, there are 2 regions, one does early cholecystectomy and the mortality is 10 times higher than the region that does late cholecystectomy. If you were sending a paper to the New England Journal of Medicine and you say we can reduce the mortality from a certain disease by half, I would say they'd grab it with both hands. If you said we could double the survival for some particular condition, again, there aren't, those papers don't come up. And if you say we can reduce the mortality by 10 times, and if they say no, nothing, so I just find it interesting that, but then looking back over the years with some great ideas by great clinicians, and why did the people around them not see it? Why did they not see Semmelweis's hand washing technique? You wonder if it's just personality. Was Semmelweis such a pain that you liked the idea but couldn't stand the messenger? I don't know.
No, I agree. I've thought about that a lot. These concepts of Kuhn's theories of Kuhn's ideas of paradigm shift are really interesting. I have my own theory of paradigm shift, just to sneak it in, is that paradigms change when the proponents of those paradigms die. You finally get rid of them, and some sensible can come in. Anyway, I think Martin wants to continue. So thank you very much, Tom. Most grateful.
Not at all, Wayne. Thank you.
Thanks very much, Wayne. Again, Tom, an excellent talk. Truly excellent. I think surgery is constantly evolving and looking for new techniques, and you've addressed most of these concepts, and in fact probably all of those concepts in your talk, and particularly laparoscopic surgery, how we may have felt about that at the beginning of our careers, and how an important place and what an important role it plays now in surgery. If you look to, I'd say, the treatment of appendicitis, which is the classic surgical disease treated by the classical surgical approach of appendicectomy, there is consideration now to look at whether or not antibiotics can be used with effect.
Yes.
Now, some studies are supportive and others are not, and the recent one from Dublin suggests that it is not. But that may be careful patient selection. But what you say is very interesting in relation to cytokine response and the individual host, if you like, or patient response, of how that might be affected. So I think that in the future, perhaps surgeons will sign themselves out, and maybe society might look back on us with great respect. But I think the greatest respect actually is owed to the patients of history, who had to tolerate so much pain and stress before we had Murden from Boston and ether and so forth. So again, I think we're running out of time, and I do want to thank you very much for a wonderful presentation. And thanks all who signed in. Please encourage your friends and colleagues to join us next week for Medicine and the Holocaust, which I think will be an extremely interesting talk. And I look forward to seeing you all then. In the meantime, stay safe, and thank you very much.
Thanks, Martin. Thank you very much. Thanks, Wayne.